ELPA, as a patient association, holds during the International Liver Congress of European Association for the Study of the Liver. So now I will give the word to my Vice President, Mr. Achim Kautz, who was in charge of this meeting. Achim, please. Thank you.
So, welcome everybody, and hello. So, I think it's a great pleasure for us to have the opportunity to work with these guys together. And when we thought about thinking, what is the lag for the patients who are drug users and have hepatitis C? So we were in the process to communicate all the problems, and I'm very proud that we now have the possibility to have this expert recommendation to focus on the main issues. And I hope that you will be able to understand how important it is to give this information we provide here today to your patients all over Europe. Thank you very much.
Good morning, everybody. Good morning. First of all, I want to thank the President of ELPA and the European Liver Patient Association for inviting INSHU, the International Network on Hepatitis and Substance Users, to present the interim results of the guidelines, the recommendations on the management of hepatitis C virus infection in patients, in persons who use drugs. The issue is an international collaboration of scientists, addiction medicine doctors, hepatologists, and allied healthcare professionals devoted exclusively to the diagnosis and treatment of hepatitis in substance users. They organized, up to now, several international congresses to disseminate the knowledge and to stimulate the research on this topic. They educate international and national health authorities on prevention, diagnosis, and management of hepatitis in substance users. During the last year, they felt the need to develop guidelines that might help care providers to treat hepatitis C virus in substance users. We are happy to present those guidelines today to your Liver Patient Association. In the next hours, we will cover several topics on this domain. My name is Geert Flobhuis. I'm coming from Leuven. My co-chair is Professor Maus from Germany. I propose we start this meeting, and we propose to take questions after all the presentations. Thank you. It's my pleasure to introduce the first speaker, Dr. Maria Prins, who is Professor of Public Health and Epidemiology of Infectious Diseases at the AMC in Amsterdam, the Netherlands. She is a senior epidemiologist. Since 1999, she heads the research department on infectious diseases at the Public Health Service of Amsterdam. Her presentation is entitled Epidemiology and Prevention of Hepatitis C viral infection in patients who use drugs.
Thank you. I have no financial disclosure. In the next 10 minutes, I will give you a short introduction on the epidemiology of hepatitis C in people who use drugs, followed by an overview on hepatitis C prevention, distinguishing the following population: the unaffected population, the infected population, and the population who have cleared the virus spontaneously or on therapy. I will end my talk with some draft recommendations that we are working on. Today's epidemiology. People who inject drugs account accounts for the majority of new hepatitis C infection. In the past 2 decades, there are some new at-risk groups, like men having sex with men with acute hepatitis C. They are mainly HIV infected, and also migrants originating from hepatitis C endemic countries. However, in many countries, still people who inject drugs are the major transmission group and the major group of the HIV-affected population. It has been estimated that worldwide, about 60 million people injected drugs. Nelson and All did a tremendous job by systematic reviewing over 5,000 peer-reviewed and grey literature resources for anti-hepatitis C prevalence in people who inject drugs on the country level. Globally, about 10 million people who inject drugs are estimated to be infected with hepatitis C, corresponding with a prevalence of 67%. This map shows the prevalence estimates of injecting drug use in the general population. Many countries have a prevalence between 0.25 and 0.5, but for most countries, here in orange, there are no good estimates, or it is unknown, here in grey, whether any injection drug use has been practiced. If it is unknown whether and how frequent drug use is practiced, then also data on hepatitis C prevalence are of course not available, as can be seen in this map on the hepatitis C prevalence in people who inject drugs. You can see that in the grey and white areas, still data are lacking on prevalence of hepatitis C and prevalence of injecting drug use. Sufficient data on hepatitis C prevalence were located for 77 countries, and the prevalence is about 60 to 80% among people who inject drugs for 25 countries, and 80% or even higher in 12 countries, demonstrating that hepatitis C is controlled very efficiently by injecting drug use. There are 6 genotypes further subdivided in subtypes, and they provide clues about the historical origin and also the spread of the virus. Subtypes 1A and 3A are particularly circulating among people who inject drugs worldwide, and they showed an exponential growth during the 20th century. But all other genotypes and subtypes are also present in this population. And subtype 4D has entered the Southern European population relatively recently through just one or a few introductions, and through movement of people, it is effectively spreading now in Western Europe since the 1960s. What about the trends in hepatitis C incidence, new infection? It ranges from 5 by 45 cases per 100 persons followed in 1 year, and it exceeds the HIV incidence. There's also promising news, and that's that there has been observed a lengthening in time to hepatitis C infection since onset of injecting, but still, 1 year after starting of injecting, 25% of the injection drug users is already hepatitis C infected. Other promising evidence is that there is an evidence for declining trends in the incidence of hepatitis C and other blood-borne viruses in North America and the European Union. And this is one of those studies, that's the famous Alive cohort from Baltimore, with the dark block shows a decrease in incidence of hepatitis C over time. Now I'm moving to preventing. Preventing infections in the unaffected population. Ideally, you would have a vaccine. Progress to an effective vaccine for hepatitis C is limited, so today we don't have a vaccine. What about reducing risk behavior by harm reduction measures? Harm reduction programs for people who inject drugs have the following key components: opiate substitution treatment or other drug dependency treatment, provision of needles and other clean injecting equipment, health promotion and education, condom provision and social care. Often also regular testing for hepatitis C and other blood-borne and sexually transmitted infection is part of such programs. However, is there evidence that such programs affect the hepatitis C incidence? Now, there is good evidence that those programs reduce self-reported risk behavior, and there's also some evidence that it prevents HIV transmission, but the evidence for hepatitis C transmission was until recently weak, or at least insufficient. However, recently there are some original studies that show that comprehensive harm reduction programs that combine opioid substitution treatment and needle exchange program are effective in reducing hepatitis C transmission. The first evidence came from our own cohort in Amsterdam, and we demonstrated that people who fully participate in harm reduction program, that means they get sufficient methadone and they have always used clean needles, that they have a 46 reduction in the risk of getting hepatitis C infected compared to individuals who do not participate in such program. A study from the UK recently confirmed that full harm reduction with the high coverage of needle exchange program reduces the odds of new infections by nearly 80%. And also a review by Holly Hagan from the United States showed that not single interventions but multiple combined strategies reduce the risk of hepatitis C seroconversion. What about testing? Does testing prevent new infections? The EMCDC, together with the ECDC, did a review of published reviews, and they show some but weak evidence that knowing that you're negative changes your injecting risk behavior. There are no evidence that it will protect hepatitis C transmission, possibly due to a lack of primary studies. Now I will move from preventing infections in the unaffected population to preventing transmission by the infected population. And I will again first address testing. If you know that you are positive, does it help, does it reduce your risk behavior? And again, there are no reviews on the topic. However, observational studies and modeling studies suggest that testing leads to efficient linkage to treatment access and might reduce forward transmission. How does it work? We know these days that people who inject drugs can successfully be treated with SVR rates comparable to rates to people not injecting drugs. However, hepatitis C treatment uptake is still low, often around 1 or 2%, but there are more higher uptake rates recently found in some of the high income countries. And available data suggests that higher uptake and adherence rates in integrated services targeting people who use drugs are effective. There's a very nice poster 988 at this conference from the United States. They did a randomized controlled trial on integrated care versus universal care, and they really show that integrated care resulted in a higher uptake of treatment for hepatitis C among people who inject drugs. So treatment reduced the future burden of disease. That has been based on modeling studies, because treatment has been applied relatively recent, but you can model that looking forward in the future. And the same has been done to look what is the effect of treatment on forward transmission. Can you reduce transmission? And this very nice study by Natasha Martin from the UK shows what happens. When you go to the left upper panel, you can see on the x-axis the baseline chronic prevalence, and on the y-axis you see the relative reduction in prevalence. And when you look to baseline chronic prevalence of 14%, and you will treat 5,000 drug users annually over 10 years, then you will have about a 10% reduction in the prevalence over time. If you increase treatment of drug users from 5 to 14 by 100 years, you can see that the increase in the decrease in hepatitis C prevalence, as the decrease in new infections, is more substantial, advocating for higher increased rates of treatment in drug users. This is still theoretical, but I think it's a very important message that you might use treatment as a prevention measure. Finally, you also would like to prevent reinfection following spontaneous clearance and successful treatment, but Jason Gregory will talk about this topic in detail later on, so I'm not going to show you any slides on this. I will end with the recommendations for people who inject drugs with regard to hepatitis C prevention. So people who inject drugs should be routinely and voluntarily tested for hepatitis C antibodies together with testing for other blood-borne infections, sexually transmitted infections and TB, preferable at regular intervals. And hepatitis C RNA testing should be performed if recent exposure to hepatitis C is likely. And of course, testing is very important for linkage to treatment. And also, vaccination against hepatitis E and B should be offered to people who inject drugs. People who inject drugs should be provided with clean drug-injecting equipment and opiate substitution treatment as part of widespread comprehensive harm reduction programs. Health promotion, including risk reduction counseling and information on testing and treatment, should be provided to people who inject drugs, and this is very important for linkage to treatment. And finally, hepatitis C treatment, according to clinical guidelines, should be offered and linked to testing and other services for people who inject drugs. And treatment should preferably be delivered in settings targeted to the needs of people who inject drugs. And there should be appropriate support to increase adherence. Finally, I would like to thank the organizers of the symposium, especially ELPA, and also I would like to thank you for your attention.
It's now my pleasure to introduce my co-chair, Gerd Rouet. He's professor at the University of Hasselt and visiting professor at the University of Leuven, and quite importantly, co-founder of the International Network on Hepatitis in Substance Users, and he's presently the vice president of this organization. His talk will be on barriers to screening and treatment of HCV in people who use drugs. Gerd.
Thank you. Dear ladies and gentlemen, as you have heard, hepatitis C viral infection is very prevalent in substance users. However, there remain major barriers to screening and treatment of HCV in people who use drugs. This is my disclosure slide. As you know, antiviral treatment for hepatitis C viral infection constitutes of several compounds. Classically, pegylated interferon is combined with ribavirin. It is given during half-year to a year period. Pegylated interferon subcutaneously once a week. It has immunomodulatory mechanisms. Ribavirin is associated per orally twice a day, and it has mainly antiviral mechanisms. Nowadays, in genotype 1 patients, boceprevir, telaprevir have become available in a lot of countries all over the world. They are administered per orally several times a day, and they have a direct antiviral mechanism. The outcome can be measured as sustained viral response. This means the disappearance of HCV RNA 6 months after end of antiviral treatment. And it varies depending on the genotype from 50 to 80%. In persons who use drugs, antiviral treatment has to be organized in multidisciplinary centers. This constitutes a collaboration of the substitution center and their addiction medicine doctors, antiviral treatment center, and hepatologist, infectiologist, depending on the country. Psychiatric problems have to be treated before and during antiviral treatment by psychologists and psychiatrists. Since those patients have a lot of financial problems, have problems with homelessness, imprisonment, they have to be referred to the social department. Those centers can be organized in different ways, but most important is the very efficient collaboration between all those departments. And that can be organized under one roof, or where they are in the immediate vicinity of one another in close relationship with one another on a small distance. In those circumstances, the outcome of antiviral treatment in people who use drugs is similar as in non-substance users. However, the treatment uptake remains low. In hospital-based liver clinics, it varies from 60 to 42%. In the community, it was even lower, 1 to 60%. What are the barriers and how can they be overcome? They are multifactorial and they can be classified according to WHO in patient-related factors, condition-related factors, healthcare team-related factors, health system-related factors, and socio-economic related factors. Patients experience their barriers as barriers concerning ongoing or former drug use, ongoing alcohol use, treatment for drug dependency, psychiatric disease, older age, minority, ethnicity, comorbid medical disease, and advanced liver disease. As will be shown by Professor Scheffer, when psychiatric diseases are treated in a very efficient way, they are not a barrier for most of the patients anymore. Also, ongoing alcohol use and moderate drug use is not an exclusion criterion anymore for receiving antiviral treatment. Patients experience as barriers lack of information about screening and treatment and social problems. Especially limited knowledge of testing locations and limited accessibility of testing results and treatment are major barriers. They can be overcome by giving information on testing and on treatment locations in the surroundings. Non-invasive tests become more important by combining biomarkers of fibrosis in the serum and offering the possibility for transient elastography. FibroScan offers the possibility to score fibrosis and not doing an invasive liver biopsy. By saliva tests, HCV antibodies can be screened with a sensitivity of 98% and a specificity of 99% nowadays. A second factor as barriers is the history of incarceration and homelessness. And therefore, it is very important that care has to be offered in prisons, and this will be taken by Professor Steuver, and in difficult social conditions. It is very important that patients are evaluated about housing, education, cultural issues, social function, social support, finances, nutrition, drug use, and alcohol use. Patients should be linked into social support services. Condition and treatment related factors were very important in the past. Concerns about high treatment toxicity were very important. They have been overcome nowadays, but it remains the question what will be the influence of the side effects of the new antiviral medications which come available today. Healthcare team and healthcare system related factors are also major barriers. It is clear at this moment that attending one visit with an HCV specialist is the strongest independent predictor of HCV treatment. However, the experience of the specialist has to be important, otherwise it remains a barrier. General practitioners become also more and more important because it has been seen that as a patient, having seen a general practitioner about HCV in the last 6 months increases 4 times the likelihood to be assessed for therapy by a specialist. When the general practitioner is living on a long distance of the treatment centers, this can be overcome nowadays through the use of telehealth technology, ECHO, which has been developed in the United States, Extension for Community Healthcare Outcomes, offers primary care providers from underserved areas training, advice, and support in delivering best practice care for patients with complex health conditions. Also, hepatitis C virus is of major importance by giving information on hepatitis C, on the treatment, on the substitution therapy. The nurse increases the uptake for antiviral treatment with 3 times. Not the efforts of all the care providers on their own, but especially the combination in a full model is of major importance for increasing the uptake of persons for antiviral treatment. Patients can organize themselves, they can give peer support, it can be offered by a former or a current substitute, information concerning substance use and substitution therapy, and HCV and antiviral treatment by a peer person can increase the chance for attending appointments. And there are now several studies which show that the attendance is higher and that also the uptake for treatment is higher. Also, by organizing in a center direct observed treatment, a care provider who sees every time the patient when he comes for treatment increases not only the outcome of treatment, but certainly the uptake for treatment. And those data has to be enlarged in larger scale studies. Up to now, there was a lot of thinking that socio-economic factors would be a barrier for treatment. The cost for treatment was not available for patients who are infected by drugs. That was thought in society at a large scale. However, new data, which have come from the study which has already been mentioned, show that it is more cost-effective to treat substance users in comparison with non-substance users with hepatitis C viral infection. So, we think we may conclude with evidence and recommendations, and here we have listed how we have scaled our evidence and recommendations. Evidence is scaled from high quality to low quality, from A to C, and recommendation is offered as strong to weak, from 1 to 2. And we think we may say that the uptake for people who use drugs, the uptake rate is low at this moment. This can be increased by helping the patient, by education, offering peer support, caring for social problems, and offering non-invasive tests. It is important for the healthcare team and also for our healthcare system in general to offer multidisciplinary centers where there is a good collaboration, where there is also direct observed treatment. At this moment, there is no socio-economic reason anymore to exclude people who use drugs for antiviral treatment. I thank you.
Professor Gravely from Australia. He is a senior lecturer in the virus hepatitis clinical program at the Kirby Institute in Australia. He has a large experience in research, including epidemiology, natural history, and therapeutic strategies for acute and chronic hepatitis C viral infection in injection drug users. He published a lot of important manuscripts in this field. His lecture is entitled "The Impact of Drug Use on Adherence and Response to Therapy in People Who Use Drugs."
Perfect. Well, thank you very much, and I'd like to thank Geert and also to ELPA for inviting me to speak. So, as Geert mentioned, I'm going to discuss a little bit today around the impact of drug use on adherence and response to therapy among people who inject drugs. So I just want to run through an outline of what I want to go through with you today, and so a number of issues. So first, how should we be defining adherence and how should we be looking at adherence among people who use drugs? What is the impact of drug use prior to and during treatment on adherence? What factors are associated with non-adherence? What is the impact of drug use prior to and during treatment on subsequent SVR? And then lastly, what do we know about factors associated with not attaining a sustained virologic response among injectors? So really, some of the early data around what impact of adherence is on SVR, and we know that adherence is important in achieving an SVR. And so this is a study from Diana Silvestri's group in Oakland, looking at 71 patients receiving methadone maintenance therapy. They received standard interferon plus ribavirin, and adherence was defined as 80-80-80, so having received 80% of the PEG, 80% of the ribavirin for 80% of the time. So just under 2/3 used illicit drugs during treatment, and about 1/3 of these used sort of, I guess, hard drugs, meaning sort of heroin, cocaine, or methamphetamine, and just over 2/3 were adherent to therapy, defined by this 80-80-80 rule. And not surprisingly, individuals that were adherent to therapy did significantly better than those that were non-adherent, as demonstrated by a 42% SVR in those that were adherent, as compared to 4% in those non-adherent to therapy. Now, I think we need to be really careful, and I think we need a little bit of a paradigm shift in how we look at adherence to hepatitis C. And when we look at this, we can look to the field of HIV, who have done a considerable amount of work looking at adherence. So as I mentioned, this 80-80-80 rule defines as 80% of PEG for 80% of ribavirin and 80% of the time. And the problem with this 80-80 rule is that there's often no distinction made between the missed doses that happen during therapy and actual treatment discontinuation. So this is some work that was published last year in the Journal of Hepatology that we did, coming from the Australian trial of acute hepatitis C. These are individuals with HCV monoinfection that were treated for HCV. And I'll just draw your attention. So the empty boxes are missed doses, or doses that weren't received. The gray boxes were dose modifications or dose reductions. And in blue is the doses received. And I just want to draw your attention. So if you look at, on the right here, we see that the majority of doses were actually received on therapy with a relatively high compliance. And we see very few missed doses during therapy. And if we look at, so really, when we're looking at adherence, the majority of this contribution is due to discontinuation of early therapy, if you look at the white boxes. And so if we look at the SVR and those with adherence, not surprisingly, individuals with higher adherence to therapy achieved a higher SVR, 67% versus 35%. And when we looked at the SVR in those that missed doses versus those that didn't, it was actually relatively similar. And the SVR in those discontinuing therapy between 0 to 4 weeks was 9%, 5 to 19 weeks, 33%, 20 to 23 weeks, 43%, and 24 weeks was 76%. So just trying to drive home this point that really we need to consider missed doses during therapy in addition to treatment discontinuation, because I think it's important. So what do we know about impact of drug use on adherence? Well, we know that a history of injecting drug use and recent injecting drug use at the time of treatment initiation actually have little impact on adherence. We also know that with respect to treatment completion, it's not compromised by injecting drug use history or recent drug use at treatment initiation. Now, I need to sort of, there are some studies that have shown a lower treatment completion in those that have a history of injecting or recent drug use at the time of treatment initiation, it's supposed to be said. What else do we know? Well, we know that occasional drug use during treatment does not seem to impact adherence or treatment completion. However, there are some studies that have demonstrated that lower adherence has been observed in people with frequent injecting during treatment. So this being sort of daily or every other day. And when we look at factors associated with adherence or treatment completion, very little work has actually been done in this area, but lower education and unstable housing has been shown to be associated with lower adherence and poor treatment completion. So just to sort of complete the adherence component, with respect to the recommendations, so adherents should consider missed doses and treatment discontinuation, and people who inject drugs should be counseled around the importance of adherence, so both missed doses and full treatment completion in terms of attaining an SVR. Now, what else do we know? We know that Geert mentioned that treatment is highly effective in those with a history of injecting. This is a study that was done by Margaret Hellard, a systematic review of the evidence, looking at a number of studies, looking at treatment among injectors, and the median SVR was, so regardless of the treatment regimen, was about 41%, and in those receiving PEG interferon and ribavirin, it was 54%. This is some recent work that's actually sort of the first peek at the data, because it's just in preparation, and this is a systematic review that we're working on with Esther Apsenal and Margaret Hellard, looking at SVR among people in studies where people have been actively using injecting drugs. And what we see is that, first of all, there hasn't been a large number of studies done to date, but the SVR in fairly consistent across the studies, but was sort of 62%. I think we need further data around randomized trials of different treatment strategies. This is probably one of the first randomized trials among active drug users, and it looked at directly observed HCV therapy. This is a study led by Sam Lee in Calgary in Canada. And what they did is they randomized individuals to immediate versus delayed HCV treatment. So mean age of about 42, 91% male, 45% genotypes 2 and 3. So stimulant, depressant, and narcotic use in about 3/4 of patients. Stimulant use in 3/4, depressant in 11%, and 22% had narcotic use. And what we see is a relatively high SVR, 63% in those that received immediate therapy and 58% in those with delayed therapy. Now, the one caveat to this is in the delayed arm, there were actually 6 individuals who were lost to follow-up during the follow-up period, suggesting, so if you looked at the results on an intent to treat analysis, the SVR in the delayed group was actually much lower than this. This is sort of the individuals that received 1 dose of therapy, suggesting that we actually, if we defer treatment too far and don't take the opportunity when people are actually ready to go on to treatment, we may lose people in this process. What about the impact of ongoing injecting on SVR? So this is a study that we did in Vancouver in Canada at the Pender Community Health Center, led by Brian Conway's group there. And so about 1/3 had used illicit drugs in the previous 6 months, and about half used drugs during treatment. And frequent is defined as greater than weekly in this study. And so what we see is that if you look at the individuals that had a drug abstinence of greater than 6 months versus those that had used in the previous 6 months, you see that there's not a difference in sustained virologic response, obviously small numbers. But if we do look at those with illicit drug use during treatment and compare those with no drug use during treatment to those that had any drug use during treatment, we don't see a difference. However, when we broke this up by occasional users versus frequent users, we did see a decrease in response, suggesting that perhaps those with more regular use, that might impact SVR. This is really small numbers, and we need further data in order to sort of get at this a little bit more clearly. So what do we know in terms of the literature about the impact of injecting on SVR? Well, we know that HCV treatment does not have an impact on drug dependency treatment or increased drug use. This is a concern among some clinicians. We know that recent drug use at the time of treatment initiation is not associated with a lower SVR. We know that HCV treatment can be successful for persons who use drugs during treatment, and as I showed you, perhaps frequent use may lead to a lower SVR, but I think we need larger studies as the sample sizes have been very small looking at this to date. What about factors associated with SVR? Again, we could use more literature here, but factors associated with a lower sustained virologic response among people who inject drugs include poor social functioning, a history of untreated depression, and ongoing drug use during treatment. But it's a package, It's very difficult to separate some of these things because they're so closely linked. So what about the recommendations? Well, treatment of HCV can be considered for persons even if they currently use drugs, provided they wish to receive HCV treatment and are able and willing to maintain regular appointments. A history of injecting or recent drug use at treatment initiation is not associated with SVR, and it's actually very difficult to predict who will discontinue due to drug use prior to treatment initiation. So it just needs to be based on an individual case-by-case basis, not based on drug use alone. So as I said, so people who inject drugs should not be excluded from therapy based on a history of injecting or recent drug use at the time of treatment, and decisions need to be made on a case-by-case basis. And people who inject drugs with ongoing social issues such as education and housing, a history of psychiatric disease, so depression, and those with more frequent drug use during therapy are at risk of lower adherence in SVR, and they need to just be monitored closely during therapy. I think that's just, Okay, so now I just wanted to sort of go through some areas for further research, and I think it's important to consider the fact that although I've mentioned all this, there's some caveats to what I've said. And first thing is that people who inject drugs actually have very favorable treatment outcome characteristics. So they're generally younger, early disease, high proportion with genotype 2-3. So it's not that surprising that they would be, they would do as well as they have, because you'd expect them to respond better given more favorable treatment characteristics. So, and so when we look at the studies examining outcomes and adherence in this group have generally had very small sample sizes. So we need further studies in this area to bolster the evidence with respect to this. And I think we need to be careful, because sometimes we sort of bring together former and current people who inject drugs, and we combine this term where it's a very, it's a continuum, and it's a very gray area. People relapse in and out of drug use. And so, we sometimes sort of take these conclusions and apply them to people who are currently using drugs. So I think as I mentioned before, we need further studies in this area. And, I think one step in this regard is, we've been leading a study. The PIs are Greg Dorr and Olav Dalgard, and a number of the people in this room are investigators and on the panel, which is the Activate study. So this will be one of the first international prospective trials to evaluate treatment among active injecting drug users with genotypes 2 and 3. So this will be 100 patients, and if they achieve an RVR, they'll be truncated to 12 weeks of therapy. So, this will give an opportunity to establish this international network. If you have clinics, we'll be planning future Activate trials, and so, please feel free to contact us, and if you're interested in being site for future studies. So I guess I'd just like to sort of acknowledge a couple people, Greg Dorr, who's my mentor in Sydney, Esther Absalom, who provided me with some of the data from Health Protection Scotland, and Geert Robees and ELPA for inviting me to speak. So thank you very much.
So our next speaker who will reach, hopefully, the podium without any accidents, is Martin Schäfer, who is coming from Essen, which is the neighborhood of Düsseldorf, where I'm based. He is professor of psychiatry at the University of Berlin and is now head of the Department of Psychiatry at the clinic in Essen.
Thank you very much. Thank you, ELPA, for inviting me. I will cover the field of psychiatric comorbidity in patients with drug users. These are my disclosures. And there are several reasons why you can have some psychiatric problems during treatment of HCV. These are the high rate of psychiatric comorbidity in those patients. This is the HCV infection itself, which may lead to some problems like depression. This is antiviral treatment with interferon alpha and concomitant drug or alcohol abuse. So as you can see on the slide, it's very, most patients with hepatitis C infection have an increased rate of psychiatric comorbidity. You see here that depression is very common and more common than in the general population, anxiety, bipolar disorder, schizophrenia, beside drug use and alcohol abuse. But we also know that nearly every patient with drug abuse has also psychiatric comorbidity, one or two comorbidities. Again, depression, personality disorder, schizophrenia, bipolar disorder, or other problems are seen very frequently in those patients. And psychiatric comorbidity is still one of the most important reasons for non-treatment of patients for chronic hepatitis C. So the question is this really based on evidence, on clinical data? And start with the evidence that we have for psychiatric comorbidity and hepatitis C treatment. And what we know is that psychiatric risk patients, that means patients with psychiatric morbidity with chronic hepatitis C infection, can be treated using the currently approved regimes. And psychiatric risk patients do not have an increased risk for early antiviral treatment discontinuation, for lower compliance, for lower sustained virological response rates, for higher risk for severe depression during treatment, and a higher mean increase of depression scores during treatment. So these are the results of the data of the last 10 years. I just want to show you some single trials, one trial of our group, which compared risk patients with non-psychiatric controls. These were patients with severe psychiatric disorders, schizophrenia or severe depression. These were patients with methadone substitution treatment or former drug abuse not being substituted at the moment, and controls without psychiatric disorders. And what you can see is that there were no significant differences in the sustained virological response. These differences here came from the higher number with genotype 2 and 3 patients, and there's no difference in the appearance of major depression during treatment if the patients are treated in a multidisciplinary team. But you have a slightly increased dropout rate in drug users coming in the first 4 to 6 weeks of the treatment. There you have to care for the patients in a special way. And here I show you the different types of depression during treatment. What you can see here is a differentiation in mild depression, moderate depression, severe depression. Most patients will not develop severe depression during treatment. Most patients will develop mild depression, and that may be over 60% of the patients. The other 20 to 30% will have moderate depression, but many of the patients with severe depression are controls. So it is not only important to care for the psychiatric patients during treatment, but only to keep in mind the controls. There are also data that show that there's no influence of baseline depression on SVR, no influence of psychiatric comorbidity on SVR during HCV treatment in methadone substituted patients, and no influence of depression during antiviral therapy for sustained virological response if the patients are treated properly. So what are possible relative contraindications left for those patients is acute, major and uncontrolled psychiatric disorders. These are disorders which are difficult to treat even for the psychiatrist without treating any additional somatic disorders. And these are also acute suicidal thoughts. However, the most important point is that you have to make a case-by-case decision together with an experienced psychiatrist. And even if you look to the suicidal thoughts that will appear in 2 to 6% during treatment, there's a nice trial showing that if you really screen every patient with drug addiction before the treatment, you will find in up to 20% patients with milder forms of suicidal thoughts in those patients. So that even this is not a real contraindication for the treatment. So how can we manage these patients prior to the treatment? We have to check the psychiatric history and the history of suicide attempts, because these are risk factors for later complications. We have to organize, this is the most important point, an interdisciplinary treatment setting. It is good to involve a confidant, if possible, to provide information about possible psychiatric side effects for the patients and treatment options. And it is very important for those patients to optimize current psychiatric treatment. This will take 2 to 3 months before you can start antiviral treatment. During treatment, we have to care for the patients because of the side effects like depression. Most patients, I explained to you, will have milder forms of depression, but 20 to 30% will also have moderate to severe depression. There are other side effects like fatigue, which is very frequently observed during treatment, sleep disturbance, irritability, anxiety, and cognitive disturbance, and less frequently seen there's mania or psychosis or patients with suicidal thoughts or suicidal ideation. During HCV treatment, we have again to educate the patient to monitor the side effects. We can offer them supportive psychotherapy, and we have to know the pharmacological treatment strategies. We can give them acute or preemptive antidepressant treatment. We can use other treatments for symptomatic treating, like psychosis or mania. And we want to avoid antiviral therapy dose reduction or discontinuation. This is only prospective controlled double-blind trial, but that showed very clearly that you can treat acute depressive symptoms during interferon treatment with an SSRI, with antidepressants, in this case citalopram. This was very effective in diminishing the depressive symptoms. There are no specific data in this for patients with drug addiction. There's one trial that tried to reduce symptoms of depression by psychotherapeutic treatment. This was a cognitive behavioral intervention, and this tried to diminish the depressive symptoms during treatment, but there was no significant treatment group differences on depressive symptoms over time. In the first trial, we treated patients before they started antiviral therapy with an antidepressant, with citalopram, and what you can see here is that those patients with drug addiction and depression who received citalopram before treatment developed depression in only 10%, and non-psychotic controls and drug users without antidepressant pre-treatment developed depression 50 to 60%, so this was a significant improvement for the patients. Now, there are several other trials, not only including drug users, most included non-psychotic patients, and they tried to pre-treat the patients with an antidepressant. There are some trials with negative results, but there are coming up more and more bigger trials with positive results. So it seems to me like this is very effective pre-treatment of the patients, even in case of non-psychiatric or of patients with no psychiatric history. So this will reduce psychiatric problems during treatment. So coming to putting this data together as conclusions for the recommendations, drug abuse and psychiatric comorbidity are still important reasons for non-treatment of HCV infection. If a multidisciplinary treatment is provided, psychiatric comorbidity do not negatively influence treatment outcome in patients with substance use disorder. Incidence of depression associated with interferon treatment do not necessarily differ between patients with substance use disorder, psychiatric comorbidity, and controls. Antidepressants should be offered in case of interferon-associated depression or as a prophylactic treatment, especially in case of pre-existing depression. Psychotherapy alone has not been shown to be effective for prevention or treatment of interferon-induced depression. New antivirals will complicate psychiatric management because of possible drug-drug interaction. We will hear Stefan Maus about this area. And for the other side effects, we need the symptomatic treatment, and this individual treatment strategies should follow psychiatric standard and guideline. So thank you for your attention.
The next speaker comes from Switzerland. It's Philipp Bruckmann. He's head of internal medicine and infectious diseases at Aarhus in Zurich, and he's the current president of INSO. Philipp.
Thank you, Stefan. Thanks very much to ELPA for organizing this important meeting. 10 years ago, intravenous drug use was a contraindication for hepatitis C therapy. In the past decade, there was a lot of evidence provided, so that it could be verified that treatment in people who use drugs is feasible. But most of these studies have been done in more or less stabilized patients with drug use. So the task for the next decade is to expand HCV treatment and to expand also evidence from the integrated opiate maintenance treatment patients to a more marginalized and severely affected group of people who use drugs. To reach this goal, I think an individualized approach with a bundle of support strategies is needed. In his comments in Lancet 2009, Reimer asked to integrate HCV therapy into primary care addiction treatment and to integrate community-based treatment settings with low threshold access, shared care approach, and high ratio of community to office-based appointments. So, in the next few minutes, I want to show you some evidence about effects of different strategies. You've already heard about some of them in the previous talks. And I want to start with integrated care. A study done in rural Canada in primary care-based clinics with a collaboration of nurses and physicians and a collaboration of addiction medicine, mental health and the hepatitis team. They did an interdisciplinary assessment and also an interdisciplinary management at this primary care-based location. Another study, also integrated care, but completely different, organized in a secondary care setting in a hepatology unit. It's a randomized controlled trial where they provided 9 months intervention by a hepatology psychologist to patients deferred from HCV therapy due to mental health and substance abuse problems. And they compared it with a control group with standard of care. These two studies could show that integrated care can increase efficiency of assessment and increases eligibility for treatment, and enhances treatment uptake and SVR rates in people who use drugs. Two studies about community care-based therapy, two studies from the UK, the one from Czech done in Scotland, where they had a collaboration of general practitioners, hepatitis specialists, nurse and drug workers. They did the assessment and the treatment at OMT clinics, and these OMT clinics were located at the GP praxis. And also here it was an interdisciplinary treatment indication, interdisciplinary assessment, and the interdisciplinary provision of treatment. Other UK study from Wilkinson done in London, they provided an outreach clinic in an addiction unit by a hepatologist and a nurse, and then they provided this assessment and also the therapy at this outreach clinic. There they could reach quite disintegrated people with ongoing drug use in both of these studies. The evidence from these studies is that with community and primary care-based therapy, you have a better treatment uptake, a good treatment uptake in the underserved population, and it allows successful treatment in people who did not get treatment so far. We already heard a lot about multidisciplinary settings. This is a randomized controlled trial from Italy. They had a kind of network between a drug addiction center, a mental health service, an infectious disease specialist, and a case manager. The drug addiction center, they had also an interdisciplinary team. They could show that they have a better adherence, better toxicological stabilization, and higher SVR rates in those patients who were treated in this multidisciplinary care approach, in contrast to those treated in a standard of care arm. Peer involvement, there are several studies about peer involvement. So far, I'm not aware of a randomized control trial, but peer involvement seems to improve HCV knowledge in patients, has a positive effect on distributive risk behavior, and enhances assessment of therapy and enhances also treatment uptake. Directly observed therapy. There is one randomized control trial, the one from Bonkowski. He could show an increase in SVR, but only in genotype 3 infected patients, so in those patients with shorter treatment. But all these studies could show an increase of adherence with DOT. Nurses are very often involved in such multidisciplinary teams, but the involvement is quite different. So one example, the Larry study, the only randomized controlled trial about this topic. They provided a nurse visit after each medical consultation, and the task of the nurse was to provide information about disease and therapy, and the control group had a standard procedure. Different the nurse involvement in the NOT study, where the clinical psychiatric nurse specialist provided cognitive behavioral therapy and motivational interviewing during the hepatitis C treatment and during the assessment. And this nurse was very closely collaborating with a psychiatrist, and this was also, everything was provided in a primary care-based setting. The Larry study could show that the nurse-led education improves the treatment outcome, and in the NOT study, nurse involvement with psychoeducation enhances assessment and treatment uptake. So to conclude, the recommendations about this topic, hepatitis C therapy should be considered on an individual basis and delivered in a multidisciplinary team setting. Drug dependency assessment should be undertaken, and whenever possible, OMT should be considered. Access to social support service should be a component of HCV clinical management, and peer-based support should be evaluated as means to improve HCV clinical management. Thank you very much.
Thank you, Philip. Our next speaker is Dr. Stefan Maus, who is specialized in internal medicine and gastroenterology. He is founding member of the Center for HIV and Hepatogastroenterology, an outpatient clinic and privately based research center. His primary research interests are complications of antiviral therapy and their management. He has published numerous original articles and reviews in international journals. The title of his presentation is Drug Interactions Between Psychiatric Opiate Substitution and HCV Therapies, Implications for Treatment of HCV in People Who Use Drugs.
Thank you, Brad. This is a pretty tough topic. I can make your life boring and make you all walk hard. This is some disclosures, but I decided to deal differently with that. Usually, drug interactions are not welcome in drug development, and they are killers. If you've got already drugs on the market which are well established, a drug with some interactions with the cytochrome P450 system will not come to market. Pharmaceutical companies will stop this. That's different with HCV protease inhibitors because they are first-in-class drugs, and this was the first option to add a substantial efficacy to the current HCV therapy. So we have to live with these interactions now for the time being. These interactions are frequently based on induction and inhibition of drug transporters or enzymes in gut. This is a liver meeting, but the gut plays also a role in drug interactions and the liver. They may lead to toxicity, in particular if the peak concentrations are increased, as here highlighted by the green arrow, or they may lead to loss of efficacy, in particular in antiviral therapy, if the trough concentrations are too low. because this is putting the pressure on the virus. However, you have to consider that from person to person or patient to patient, there's already quite a high interpersonal variability. So only major changes are considered relevant in drug-drug interactions. However, there's some exceptions if the drug has a small safety margin. We'll talk about this a little bit later. This is just a schematic diagram to show you there's a drug in the intestine, it gets absorbed, it's transported by P-glycoprotein, and it's already metabolized as a first pass effect, often by the cytochrome P450 system. The second step is in the liver, which is a very efficient organ in metabolizing drugs. And these metabolized are usually oxidized and then made, for example, hydrophilic, and they can be excreted by the bile or by the kidney. So the cytochrome P450 system is a family of enzymes, and each enzyme family has some drugs which are key components of their metabolism, and the most important one is 3A4 because it's involved in the majority of the drug-drug interactions. So usually if you've got a drug dealing with 3A4, that's bad news, and that's the case with tenofovir and boceprevir. Both of these drugs are substrates and simultaneously inhibitors of 3A4, which means you have to expect a lot of potential interaction. And there's no clear picture because they're inhibiting and they're at the same time substrate. So it plays always out if you've got a drug, what happens. So this is just an example, it's citalopram. It's an antidepressant. And what you can see here in blue is the combination of tenofovir and citalopram. And you can see here tenofovir monotherapy. And this is the effect of citalopram on tenofovir levels, and there's only a little variation, a little bit lower levels of tenofovir, and this is not considered medically relevant. This is non-logarithmic scale, so at least citalopram can be combined with tenofovir safely considered tenofovir levels. However, tenofovir reduces exposure to citalopram by about 35%. You can see it here, the peak concentration, the tough concentration is lower, but this drug can be raised in concentration, and you can compensate the loss of a third of the drug easily by increasing the dose. So this is a drug interaction you should know of. This is not a drug interaction being a contraindication for the simultaneous use of these two drugs. That's a bit different for midazolam. Midazolam is used for endoscopy or as a sedative, a short-acting sedative. And what you can see here, boceprevir increases drug levels by 5-fold. That's already more difficult to compensate if you sedate somebody for endoscopy with sleep instead of a few, let's say 15 minutes, perhaps 2 hours. That's not very rewarding because you will block your endoscopy suite. So if you use tenofovir, the effect can be even more profound. It's a 9-fold increase. And this for orally and IV, it's about 3.4-fold. So this is a relevant drug interaction. So you shouldn't use these both drugs together. And there's another list of drugs which may be used in IV drug users quite frequently because there's a potential of epileptic seizures in these patients. And you shouldn't use drugs which have strong 3A4 inducing potential because these drugs are highly likely to reduce your levels of tenofovir and boceprevir. And as you know, these drugs are already applied in like with 12 pills 3 times a day for boceprevir, or with tenofovir 6 pills a day 3 times a day. So if you lower the drug levels, this will most likely result in viral failure. So you shouldn't try this. So it's phenytoin, carbamazepine, and phenobarbital, which are all strong inducers, so stay away from these drugs or switch your patients before treating them for HCV. The next is, like I said, some sedatives. Benzodiazepines are not a good choice usually. There are some antipsychotics who can have a serious risk of cardiac arrhythmia, and you shouldn't try to combine these two drugs. Also, there's a lack of formal PK data because the risk of running into trouble is, and perhaps killing your patients is not worth sticking with this drug. Another relevant aspect in females is contraception. You shouldn't become pregnant during HCV therapy because of ribavirin. And this is not a real big change, but it may result perhaps combined with other factors of diarrhea, like diarrhea, like vomiting due to therapy, to suboptimal doses of contraceptives. And so you shouldn't combine an HCV protease inhibitor with an estradiol-based contraception, because you can't rely on that anymore. So you should look for safe choices. These drug, despite drug-drug interaction I've shown you already, can be considered safe because you can deal with it by increasing the dose. That's something you can safely do. Same counts with citalopram with no formal data, but the metabolism is very similar. These are anticonvulsants which are not metabolized by the cytochrome system, so they can be used in the normal way you want to use them, and there's very little likelihood of drug-drug interaction. Zolpidem, another story. This dose reduced by tenofovir by about 50%, but on the other hand, you can increase the dose safely. This is something you want to use for sleep mostly, so you can look at the effect. If it's not good enough, you double the dose, and you may get an effect. For boceprevir, there's less data, and that's a repeating issue, unfortunately. The Merck is not producing as many interaction data as does Janssen, so there are a lot of gray areas or unknown areas for boceprevir where there's data for tenofovir, and that's a shame. And it's not likely to change in the future. As antipsychotic, olanzapine is quite favorable because of the lack of cytochrome interactions. Another relevant aspect is opioid maintenance. There's only theoretical approach for heroin because there's no formal PK data. Also, this drug is now used in many countries as opioid substitution. So because it's metabolized by 3A4, you may expect interactions, but there's no data. However, as methadone is metabolized by 3A4, and there's no real interaction, the question remains if heroin has some interaction. This is also important for drug use during therapy with HCG protease inhibitors. Though we don't know, for methadone we know there was a kind of curious interaction. First, on the first things, it looked like tenofovir is reducing methadone by about 30%, but this is only done by displacement of protein-bound methadone. And the active methadone, the non-protein bound, stays the same. So there's most probably no need to change the dose of methadone upfront. So you can just start treating the patients, look if there's withdrawal symptoms, and keep them on the current dose. So that's another way of drug-drug interaction. Sometimes you have to look closer and unexpected things show up. Before boceprevir, unfortunately, there's no data in the public domain. Also, the company promised to do the interactions, but I've seen nothing. Same goes for buprenorphine, which is safe in combination with tenofovir, despite some potential for interaction shown here. So, concomitant substance abuse, because this is really tricky, as already alluded to by previous speakers. It's very likely that during HCV therapy there's concomitant substance abuse. This is data from German non-interventional study. You can see what you expect. There's a lot of cannabis use, opioid use, benzodiazepines, cocaine, and that's all documented by urine controls. And THC is highly likely to have some interactions with the cytochrome system, but because there's very little short-term toxicity, we expected, I think I wouldn't at least discourage patients from using it if it helps them sticking to the therapy, where there's some data in the public domain available. Much more seriously, maybe the interaction between amphetamine and ecstasy, because both are metabolized by 3A4 and 2D6, and there's a high likelihood of fatal toxicities if the drug is increased substantially. There are liver failures reported for MDMA, there's cardiac hyperthermia as reasons for fatalities together with ecstasy. So at least you should counsel your patients to stay away from amphetamines if they can during HCV therapy, because it's a finite treatment and the risk of being dead after having a nice weekend with some recreational drugs is pretty high. So cocaine is more difficult. Cocaine is activated partially to toxic metabolites by the cytochrome system, so it's not really clear if an inhibition may have a beneficial effect in some aspects. It's at the same time an inhibitor of the 2D6 family, but there's no formal study, and the interactions are difficult to predict. And barbiturates, I also alluded to this, are strong inducers of 3A4 should be avoided. Limited choice of antivirals, that's just mentioning that quite a few of these IV drug users are HIV co-infected, and only NNRTIs and raltegravir can be considered safe without any interaction. And tenofovir has some interactions with tenofovir, but can be used in patients on tenofovir, the deferrals will increase your costs because you have to raise the dose for tenofovir by about a third. This may increase it, at least in Germany, this will add 12,000 euros to a therapy, so you may reconsider this. And if you look at boceprevir, there's some data for atazanavir if you want to stick to PI because of resistance, which may allow concomitant use, but atazanavir dose is lower combined with boceprevir, and you may use, you can reuse veltacivir and NRTIs, but there's unfavorable data for the other protease inhibitors. Also, the study data itself showed no effect on SVR, like demonstrated yesterday, for the PIs in the HIV co-infection study with boceprevir. So that's a formal recommendation at the moment because of PK interactions. If you want to use a PI, use atazanavir in a boosted form. In conclusion, the best strategy is you have to select a few safe drugs as your choice for frequent indications for IV drug users. So use antidepressants you're sure you can use, and don't start experimentations if the lack of formal PK data. If there's clear data that the drug has a 3A4 interaction, stay away from it if you can, and minimize your polypharmacy because there's no formal data with triple, quadruple combinations of drugs. All these interaction studies are done with tenofovir plus X, boceprevir plus X, and they're not done with methadone plus amphetamines and things like this. And they're not done antihypertensive therapy plus methadone and things like this. So if you minimize polypharmacy, you have more control what you're doing there. They are not, unexpected interactions can happen if you use 3 or 4 drugs simultaneously. And what you should do, you have to tell your patients clearly, it's not dual therapy anymore. You have to expect drug interactions. It's not about having a nice weekend with a recreational drug because you had so much stress with your triple therapy. Then you can run into real trouble. And on the other hand, you have to tell the doctors, the general practitioners who care for the patients, that there's a real potential for drug interactions. So you have to educate your doctors, the physicians who see the patients best occasionally, and you have to educate your patients that they should consider their drug use a part of simultaneously with their HCV therapy. Thank you.
Thank you, Stefan. The next lecture will be given by Dr. Jason Gravely. Professor Belgaard from Norway was not available due to family reasons, and so we are very happy that Dr. Jason Gravely will cover this topic. It is entitled HCV reinfection following successful HCV treatment in people who use drugs.
Great. Thanks again, Garrett and ELPA. So I've been given a topic on something that we talk about quite a bit in this sort of sphere, but people generally don't use a lot of data when we talk about the issues of reinfection among people who inject drugs. And so I want to go through a couple of issues here, and just sort of, this is what sort of the outline of the talk. And so, look, it's clear, we know reinfection can occur, and this is a fact, but I think it's really important as we move forward in terms of understanding how we characterize reinfection and some of the definitions. And there's also this issue that treatment is often withheld from people who inject drugs based on the concerns that reinfection will negate the benefits of treatment. But this is often sort of, these claims are made based on very little evidence or just sort of concerns that clinicians might have. So I want to bring you through what we actually know in terms of hard data about this. And so really this answer this question, how often does reinfection following HCV treatment actually occur? So just to go through some definitions, I know it's a fairly simplistic diagram, but let's just bring everybody onto the same page. So when we're speaking of reinfection, we're looking at a single virus, and you get HCV clearance, and that's either spontaneous clearance, or we can have treatment-induced clearance via sustained virological response. And we have a second virus, which is distinct from the first virus, where we have a reinfection. It's possible that you become reinfected with the same virus. But so I just wanted to sort of get everyone on the same page there. Now, I I think we have problems with the wording and the definitions that we use when we talk about reinfection. So I'm just going to sort of run through some of this. And when we talk about spontaneous clearance, so if we look at the RNA status, so these are individuals that have positive HCV RNA, or potentially you might have missed that positive, but are negative using a sensitive HCV RNA assay greater than sort of 30 to 60 days apart. Generally 2 tests just to confirm sort of clearance of infection. So now recurrent viremia is a scenario where we've got positive virus, a patient, not necessarily spontaneous clearance, they could go negative once and the virus comes back, okay? Now then what we need to do is we need to sequence the virus, okay, and determine whether, okay, is this truly a viral relapse? So is this just virus, the same virus that was there in the beginning, you go negative and the immune system's trying to take hold, or is this, in the setting of therapy, a viral relapse post-treatment? And so this is homologous virus, the same virus confirmed by sequencing. And then we've got the situation of reinfection where, so if you have recurrent viremia and when you do sequencing, you have heterologous virus. So the virus is different when you sequence it as compared to the beginning. We've also got a situation where you can have persistent viremia, and we can sequence the virus and look, and the virus is similar when we sequence. And there's also this situation of HCV superinfection which can occur, where you actually get infected with a second virus which is different from the one that was there previously, or you had 2 coexisting viruses at a time point later. So I just wanted to bring everyone on the same page. And I think it's really important to understand that there's some methodological issues that we need to consider when we think about reinfection. And so the first thing is the region that we use to sequence HCV and the degree of nucleotide diversity to distinguish reinfection. And this varies depending on the region of HCV that you look at. The second problem is that our capacity to actually detect, oh, somebody moved me ahead. The capacity to detect a low prevalent quasi-species is difficult. So if we use standard genotyping technology, it doesn't pick up the low level amounts of virus that mixed infection may happen in this setting. So, the standard genotyping assay will only pick up sort of the top 80%, and virus that's present in sort of low prevalent quantities may not be detected. So if it's not a very fit virus, people who inject drugs could have multiple infections, but it could just be present at very low levels because the fittest virus is the virus that's around in the most prevalence. It's like picking something out of a bag of 100 Smarties, and if you only have one Smartie, your chance of picking out the blue one is going to be difficult if they're all red. All right, so I wanted to sort of get that. And then the other important thing is the HCV RNA testing interval. Okay, so I'm just going to quickly, so I've discussed it a little bit, but this is the HCV genome, and we, this is the sort of structural region, so the core protein, and this is relatively conserved when we look at HCV sequencing. We've got this sort of region called the E1, so this is the envelope region, and this is the E1 HBR1 region. This is actually a fairly highly variable region of the virus. And we've got sort of the non-structural proteins, and in particular NS5B has been used in the literature for molecular epidemiology purposes. But so it's important to understand that it does matter which region you're targeting to sequence when you're trying to distinguish reinfection. I just wanted to touch on the issue of testing interval. So these are some figures. They look a little complex, but they're not too complex. So in the top graph here, what we're looking at is an individual that becomes infected with hepatitis C and demonstrates spontaneous clearance. So this is in treatment. But so they demonstrate spontaneous clearance, they become reinfected, and this is an individual that you would hypothesize would have some protective immunity. So what happens is the viremia becomes less upon subsequent exposures, and the duration of infection is shorter. Okay, so this is an individual that you could, that might have protective immunity. Now, what I wanted to draw your attention, okay, and in slide B, this is an individual that might just have genetic disposition to clearing infection, so every subsequent reinfection event that happens, it's the same HCV RNA level, and it's the same width of duration of infection that occurs. And then this is an individual that becomes reinfected and becomes persistent. The point that I want to make, is that how frequently you test people for HCV RNA will determine how much reinfection events that you pick up. So if you only test people every year, you're not going to pick up reinfection events that spontaneously clear. So in this case of persistence, it's no big problem. But in this case, if you're testing yearly, you're going to miss a lot of cases. So I think this is important as we move forward and think about when we're testing people following treatment. It does matter how often you test, and it becomes an issue to consider. Okay, so the data. What do we know about reinfection following spontaneous clearance, or sorry, treatment-induced clearance? We know that the treatment, or the reinfection rate is actually quite low. Okay, so when the problem is that I don't want to go through every study in detail, but the numbers are actually small. The proportions of people that are actively injecting post-treatment it varies between studies. But on sort of when we look at it sort of pooled, the overall incidence is about 1 case per 100 person years. And I say that because we've been working, and this is some more data from Esther Absenal and this work that we've been doing with Margaret Hellard and at the Burnett Institute, and this is a systematic review looking at studies of reinfection following successful treatment among people who use drugs. And what we can see is that looking at the pooled estimate of the reinfection following treatment, it's about 1 case per 100 person years, hence why I made that statement in the previous slide. So, I think there's a couple of caveats. I think these are all small studies. The proportion that are actually actively injecting following treatment varies, and we really need more data and more larger prospective studies to look at reinfection post-treatment among people who inject. This is just some data from the Australian trial on acute hepatitis C, which was recently published in Hepatology, looking at reinfection and mixed infection. And so we looked at 163 individuals, 111 were treated for HCV, and 88 had treatment-induced HCV virological suppression. So this isn't sustained virologic response, this is just they went negative once. And I think that's important as well. We can't just be following people post-SVR. If they go negative once, they're still at risk of becoming reinfected after going negative during treatment. So we sometimes may miss people and figure that it's a relapse when in case it might be a reinfection. And so of these individuals, we had 17 with HCV reoccurrence, and of those, when we sequenced the virus, 12 had viral relapse, 4 had HCV reinfection, and 1 had a possible reinfection. And the reason I say possible is because we couldn't sequence the virus in one of those time points because the viral load was too low. But what we saw is that of the 4 cases with reinfection that were identified, so one of them actually spontaneously cleared reinfection, and 3 remained persistent. I'll go through the cases in a second. And then in terms of those with spontaneous HCV clearance, we had 3 individuals with recurrence. One of those had reinfection. This figure has an error in it. But I think there's 1 reinfection and 2 possible reinfections there. So this is just a figure looking at one representative case with persistence following reinfection. So this is an individual with a genotype 1A infection, received treatment with pegylated interferon monotherapy for 24 weeks. You can see this is the estimated duration of infection, and this is the HCV RNA. So the shaded region just shows the HCV RNA, and we see that he had an end of treatment response when he was, so when HCV RNA testing was performed later on, it was a genotype 3A. We used sequencing in the E1 HVR1 region to demonstrate this, and develop persistent infection. And you can see the ALT levels also increased upon reinfection. Here's an individual, patient 1101, initially infected with genotype 3A, was treated with PEG interferon monotherapy, and at approximately 540 days was infected with a genotype 1A infection, which was also sequenced by E1 HVR1. We see that the individual controls reinfection and ended up spontaneously clearing infection. Now I should note that this is in the setting of acute infection, so that's important, but there are case studies in the setting of treatment following for chronic infection where we've seen reinfection spontaneously clearing. So it's something to consider, but I think we need to investigate this a little further in terms of how often does reinfection occur and how frequently does spontaneous clearance of reinfection occur. So just in terms of the recommendations, so people who inject drugs should not be excluded from HCV treatment on the perceived risk of reinfection. I think that it's very important. I mentioned these studies and the low reinfection rates, but these are all multidisciplinary care programs with intensive nursing support, and they provide a great deal of education to patients about the risk behaviors. And so harm reduction and education and counseling should be provided for all active people who inject drugs in the context of HCV treatment, because we know reinfection can occur. And then following SVR, monitoring for HCV reinfection through annual HCV RNA assessment should be taken on all people who inject drugs with ongoing risk behavior. And I think the important point to make is I made that comment about the HCV RNA testing intervals, but really, if cases of reinfections occur, it's important from an epidemiological standpoint in terms of characterizing the natural history of reinfection. But in terms of a clinical perspective, you really care whether or not those reinfections become persistent. That's, I think from a clinical standpoint, that's what's important. So I don't think we need to be testing people more frequently, but yearly is probably a compromise. So thank you very much to everybody for listening.
Okay. Our last speaker is Heino Stöver. Heino Stöver is professor of social science at the University of Frankfurt. He's been involved in politics since, I don't know what, when he started medicine and started dealing with HIV and IV drug users. He was already senior, I have to say, and one to look up to, because he was shaping the politics of Germany towards HIV and drug use considerably when he was in Bremen at this time.
Thank you very much, Stefan, for this kind introduction, and thanks to ELPA for drawing the attention to this area, which is not very much studied in many ways. So, first of all, to the background, I have to say in advance that there is a lot of international human rights obligation in terms of equivalence of prison healthcare. That means the same standard and the same quality of healthcare in the community should also appear within the prison setting. And there are numerous laws and related declarations. Although soft law, there are binding in many ways, the prison medicine and the whole system. People should not leave custody in a worse condition or with poorer health than when they were entered. And addressing stigma and discrimination are very important points. And the period of incarceration should be viewed as an opportunity for public health improvement. So there are two main reports. My presentation is based on both from Australia, who put a special eye on the situation of incarcerated drug users. So first of all, the epidemiology. Worldwide, the hepatitis infection among prison populations is much higher than in the population outside prisons. And this situation often is accompanied and exacerbated by high rates of HIV, TB, and which most are multi-drug resistant, and prevalence of hepatitis C is among 6.7 to 38%, in some studies more than 70%. I have to say that in Europe, for instance, there are approximately 650,000 people in prison at any given time, and throughout the year more than 1 million people go through the system. So mostly in Europe, according to data of the MCPA, the rate of IV drug users in prison, either with the current drug consumption or with the former one, is about 30 to 40%. And hepatitis C is, in custodial settings, prevalent, and it is increasing prevalence with age, higher prevalence among female prisoners, and an increasing prevalence with multiple admissions to prison. About half of all the prisoners who inject continue to inject while in prisons, and there are numerous risk behaviors in custodial settings. Just to give you an impression which is representative for most of the Western European countries, the prison situation in Germany, where you see that we do have approximately 21% IDUs in prison, and every 7th prisoner of the total prison population is hepatitis C positive, whereas approximately 1% is HIV positive. And this is compared to the general population, of course, a manifold higher prevalence in this setting than outside. What we've heard already is that only a multidisciplinary approach is promising, and a promising approach between prison physicians, nurses, psychologists, and so on. And we need a therapeutic continuity, which is often not the case when people come into this prison setting and when they leave the prison setting, because often there is a relapse of drug use and the treatment is interrupted. And prison is a good setting for starting hepatitis C therapy, because alcohol consumption is almost not prevalent in custodial settings, although, of course, in many ways drug use is prevalent. So, coming to the recommendations we worked upon with this group, mainly at the table, 10 recommendations. And first of all, prison health is, of course, public health, so we should have more concern about what is going on in the custodial settings. We have to integrate hepatitis C in prisons into national hepatitis and BBV plans. They provide an excellent opportunity in prisons for the delivery of hepatitis B vaccination. The collaboration between correctional and public health system, a lot of improvements are needed, and the community follow-up, there's ongoing substance abuse treatment, life skills support and health education is also needed for drug treatment and harm reduction to be most effective. And what we need are clear protocols and standard procedures for the screening, testing and treatment of hepatitis. And infection control procedures and plans should be available in every institution. So when it comes to screening, testing and diagnostic, all prison inmates should be screened and tested, because it is an at-risk population due to numerous risk factors for hepatitis B and C. Prisoners are exposed in many ways. Testing and counseling should be done on a voluntary basis, and prison inmates should be screened for HPV and HCV at their arrival and undergo regular testing during their stay. Psychological counseling should be also provided, and make use of modern non-invasive assessment methods, screening techniques, but in most of the prisons we studied, this equipment is not available. So several approaches to increase the uptake should be done in terms of optimizing the approaches, raising awareness about Hep C infections, optimizing testing pathways, ensuring adequate pre- and post-test counseling, and develop care pathways for HCV that enable seamless continuity of care. HCV inmate patients who may benefit from treatment should be selected and treated, of course. Screening for co-infections is also recommended for the prisoner population group. Principles of testing, you know all about this, and this has already been said, are the same as outside in the community, of course. Confidentiality, voluntary testing are only some of the keywords. When it comes to prevention, during detention, many healthcare education activities can be carried out, in particular for persons with no or minimal prior health education, which is often the case in custodial settings. Safer use and safer sex training is recommendable. Information, education, and communication by many means, and also what Geert already spoke about, peer education is a very important method to transmit the healthcare messages, and provide proper information in the respective languages, protocol in case of needless injuries, and include prisoners, of course, in the design and conception of education, information, and programs. So participation of prisoners should be envisaged to develop a plan for vaccination for all prisons, and to develop a proactive approach for vaccination in custodial settings, taking into account the length of the sentence. And what has already been said, harm reduction in prisons is sort of a black box which is not very much introduced in many of the jurisdictions in Europe and worldwide. but it is of course the guiding principle of policy on the prevention of hepatitis transmission, and should provide and protected and safe environment for those motivated to undergo drug treatment, which affords, of course, a distance from the drug scene in prison. And bleach and decontaminants should be made available. But harm reduction is also needed in many other ways, many other risk forms, arrange facilities for safer tattooing and body art, which is very prevalent in prisons. Easy anonymous access to condom and lubricants, razors should be easily accessible, and many other devices. But there's, of course, a need, and this is the crucial point, to provide steroid injection equipment in prisons for those who continue to inject. And the only country which is doing this properly and who is covering all the prisons is, in fact, Spain. And here we have needle and syringe exchange models in more or less all the prisons. This is from Soto de Real in Madrid. And these are the devices giving out. Of course, OST is again not very widespread in prison settings, with a time lag of, on the average, 7.5 years. It is introduced in most of our jurisdictions, and but it does not have the coverage as in most of the countries as in the community, and there's a special need for scaling up these services. But they should be administered because of their hepatitis preventive role in the prison settings as well as drug rehabilitation programs and recreation services. And of course, we spoke already about the psychiatric evaluation of patients during treatment. This is badly needed, although psychiatric services are not very easily accessible in the prison settings. And this is one of the major gaps, of course, of treatment delivery. And finally, we should shift the question from why treating to why not treating in the prison setting as well. It is a very good opportunity to manage side effects, and combination therapy, the successes can be relatively high. But it is important to consider the time spent in prison preparing the patients and for potential treatment-related side effects, prescribe medications for symptom management, consider following the patients in a dedicated hepatitis clinic, and utilize peer education programs, and use, of course, nurses for management of all these side effects. And without a good support system, it is very difficult to manage this treatment efforts. And periodical psychological and psychiatric assessments should also be needed. It should only be initiated, the treatment, in patients whose detention will be long enough. I said that already. DOT strategies should be applied, and periodical assessments, and staff should be trained and supported to be supported. And also there a lot of work needs to be done. Regular training is needed for healthcare workers in prisons, which should be updated periodically. The staff should be consulted and ensure that the training of prison staff addresses hepatitis-related discrimination. Ensure that the content of all training is specific to the duties and responsibilities of various categories of prison staff. And finally, workplace safety. We should implement policies and trainings to minimize the risks of, for instance, needle-stick injuries, provide mechanisms to ensure a safe physical environment, such as hand-washing stations and so on. Ensure that all prison staff are provided hepatitis B vaccinations at no cost, and ensure that health insurances plans for prison staff are inclusive for coverage of antiretroviral changes. But finally, there remain many challenges. There are jurisdictional differences. We do have legal barriers, for instance, for introducing needle exchange programs. There are treatment challenges. The stakeholders' views are more than suboptimal within the prison setting. That we have a lot of cameralistic problems in paying for the treatment, of course, in prisons. And there are a lot of concerns about trials as against national implementation. lot of stigma and discrimination around IV drug users, and particular hepatitis C positive IV drug users around, and research and evaluation is badly needed. Thank you very much for your attention.
Thank you, Heino, for your contribution. Now I would propose to open those presentations for discussion. If you have questions, please come to the microphone, identify yourself, and we'll try to answer to your questions. Please, yes?
Yeah, Peter Moss, I'm an infectious diseases physician from the UK. I've got a question for Dr. Greabley. I work with a large cohort of active injecting drug users, and our experience is that the drug of choice is actually quite significant in managing them. In those patients who are injecting heroin, we've got quite a lot of people successfully through treatment with good completion and good SVR. But for people who are injecting stimulants, particularly crack, it's very different, to the point where we now regard active crack use pretty much as a contraindication to treatment. And just, you didn't really discriminate between different kinds of injecting drug users. I wonder what your experience with that is.
So I think you make a really, really important point. And I think one of the problems is we just don't have the data. Anecdotally, from my experiences from working in Vancouver at the clinic there, I completely agree with the observations that you just have sort of outlined. So we saw, the heroin users tended to be a lot more stable. Definitely daily heroin users are not equivalent to sort of amphetamine users and or stimulant users. That being said, I know, so actually one of the nurses who's sort of leading the program now is in the audience, and so Leslie Gallagher, I know that she's sort of successfully developed a lot of treatment programs with the crack users in Vancouver. Crack is the drug of choice as well. So I know that they have had some success, but that's, with crack use comes a considerable amount of marginalization, unstable housing, so it's a whole package of issues that are tough to address. So I think, just to bring it back for a full circle, I think what we need is more evidence in terms of the impact of injecting in different types of drugs. And hopefully the Activate study that I mentioned will, with 100 patients, at least it's a little bit larger, it's prospective, there's detailed information on drug use, and hopefully we can unpackage some of that, but we need larger collaborative studies so that we can answer these questions, because what's happening is everyone's doing their N of 40 trials, and no study has the power to look at this. And so we need larger collaborative efforts so that we can address these questions.
Dr. Isaran? Isaran from Cologne, Germany. I have a question to some of the podium. 2 years ago, we discussed with our GT1 patients, probably wait with other therapy because we may have the DAAs. Now we have them, we have the first experiences, and there are new substances at the horizon, probably less toxic, probably more effective, and so on. What do you propose this special population? Wait or start?
Perhaps I can take this first. I would say anybody who is not, I would say anybody who needs treatment with genotype 1 at the moment because of serious liver disease should be treated. But there are quite a few patients in my clinic and other clinics with good liver situations, with maybe some adherence problems, taking pills 3 times a day with meals, sometimes with real drug interactions because of psychiatric problems, and you don't want to switch the psychiatric drug, so these patients should wait. I think the future is much easier, most probably, for HCV in the next year, so if you've got real contraindications or serious complications to face, if you start treatment now and it's not necessary because of not very advanced liver disease, would rather wait. So the answer is yes and no.